Here we report a case, a young lady at age of 34. The facial profile is quite acceptable, and the front view, the odd proportion vertically is quite professional. And then the intraoral, we see that the alveolar bone is very bulgy. The upper frontal teeth are quite retroclined. Molar relationship is class 2. The lower incisors are not visible, indicating very deep overjet and overbite. If we instructed the patient to move the mandible forward, we can see that frontal teeth relationship is being improved. Means that the deep overjet, overbite is being restored. But what we have is in the buccal segment, the vertical dimension, the space is quite big, indicating a very deep curve of speed. And the OPG shows that the condyles in the two sides are not very symmetrical. The morphology of the condyles, especially in the left side, are quite defected. The SAF shows that the frontal teeth are quite retroclined, and the morphology of the mandible is quite favorable. It's very flat, and the chin prominence is quite apparent. The diagnosis for this malocclusion, we call it facial retrognathtic malocclusion subtype 2. The characteristics includes the deep curved speed, the deep overjet, deep overbite, the retroclined upper frontal teeth. Facial appearance is not too bad, quite acceptable. So if we instructed the patient to move the mandible forward, and we see quite a big space in the buccal segment, indicating the very deep curve speed. Treatment philosophy should be based on the jaw discrepancy coordination rather than correct the teeth first. Okay, so we have to coordinate the jaw relationship by orthopedics modality, and then the sequence of the treatment would be that we move the mandible forward and retract the maxilla backward, and after that we could have a coordination between upper and the lower dentition. We restore the intercuspation of the buccal segment. The sequence should be like that, other than the other way around. The treatment methods for this subtype 2 malocclusion is the S8 SGTB. S8 SGTB, the structure of this particular appliance is like we have a 2 occlusal splint in the upper piece of the appliance, and then we have a smaller blocks in the lower piece. When the patient wearing this appliance and bite together, we could have the mandible forcibly move forward, and then the 2 blocks up and the lower will be matched together to advance the mandible forward. The upper occlusal surface, we have a built-in anatomical indentation. So when opposing dentition matched to the upper one, the mandible should be reliably moved forward. Okay, so this is the one of the characteristics of this appliance. And also we have a built-in specially designed structure to enforce the rigidity of the occlusal splint, enabling the patient to chew the foods quite safely. This 8 appliance should be worn day and night, 24/7, including the meal time. So the placement of the S8 SGTB is quite similar to the routine. So we have an upper piece of the appliance to be placed into the upper dentition, followed by the lower one. Right. Okay, and then when the patient bite together, and then what we see is that overbite, overjet has been restored. The buccal side, what we could see is that we have a occlusal splint placed between the upper and the lower dentition. That's it. So open, bite. With the placement of S8 SGTB, the lower jaw is being repositionally advanced, and then the upper one, the maxilla, could be retracted quite significantly. And then after the certain time of the treatment, we should remove the individual teeth, including the upper frontal teeth. We call it deep compensation. S8 SGTB having a very important role in not only coordinating the jaw relationship, but also at the same time to correct the individual teeth, including clouding relief and the low incisal intrusion, or even some molar distalization. So the orthopedics and the orthodontic sort of effects could be taking place simultaneously.